Okay, we're going to talk about the thyroid today. We'll do this in a case study format. So first let's meet Julie. She's coming in a few minutes late for her 8 a.m. appointment. She's breathless flurry. She's 30 years old, appears healthy, neatly dressed, crisp t-shirt, jeans, and fine short hair. Puts down her bagel and her coffee and tremulously shakes her hand and apologizes for her tardiness. Says she was trying to get the laundry done before she left the house. She works part-time as an RN. She's married, 3 sons, from 4 months old to 4 years old. You ask her what brings her in today. She looks at you wide-eyed and states she doesn't really know, but her husband encouraged her to come in and make an appointment because she just has not been herself. She agrees things are just not right, but cannot further identify the problem. She reports she's not getting much sleep recently, and she stays exhausted. She says she's running around all day, caring for her family, and relates her overwhelming lifestyle as the cause of feeling disconnected and unable to concentrate at times. So, what more information do you want? We'll go ahead and do some assessment. Vitals, all look pretty good. Temps up a little, heart rate's up, respiratory rate's up, blood pressure's still borderline. She's down 35 pounds since her baby was born, so 4 months. Last period was 16 days ago. She has a visible, smooth thyroid. CBC's in normal limits. Calcium is 12.1, which is high. Albumin's normal. Cholesterol, total cholesterol is only 88, which is really low. Her pregnancy test was negative. So this is what the palpable, smooth thyroid looks like. So, diagnosis, this looks like hyperthyroid. TSH is low. T3 and T4 are both elevated. So remember, thyroid is diagnosed on the T3, T4, not on TSH. That is just the thyroid stimulating hormone, which, think back to your ANP, which is released by TSH is released by the pituitary. Remember, that is the master gland, so it sends out TSH, which is what tells the thyroid to release its hormones, which are T3 and T4. All right, so it looks like she has Graves' disease, which is the most common form here. This is most commonly an autoimmune disorder, Graves' disease. But in this one, your body develops antibodies that mimic TSH. So that's what stimulates the thyroid to produce excess hormone. However, if you were to test it for TSH, it will not show up. And I think I jumped the gun a little bit. Let's go back one slide. Look here, so you can see her TSH was undetectable. T3 and T4 were high. So she's not creating TSH, but when we look at Graves' disease, we've got that antibody that mimics TSH. So it's still telling her thyroid to create more of its enzymes. So 75% of all hyperthyroid is Graves' disease. Autoimmune, usually seen in women from 20 to 40. Other causes, you can also get a goiter, a toxic goiter that can be either hot or cold. Hot nodules are hyperactive, but they are usually benign. Cold nodules can be an indicator of cancer. You can also have exogenous sources of iodine can cause it, which we know in this country is most often found in iodized salt. Can have pituitary tumors and thyroid cancer are other causes. Pituitary tumors, so if you had a tumor on the pituitary that was kicking out TSH when it shouldn't. And then there's thyroiditis, which we all know. Itis means inflammation, so you can get this from an infection, from pregnancy, or even in Hashimoto's, which is also an autoimmune disorder, but Hashimoto's usually resolves on its own. So what does it look like? Here are some common signs. You get the goiter, which we just talked about, it's what they call it when it gets all enlarged and inflamed. And then exophthalmos, this is like bulging eyes. They actually look like they are, looks like they're trying to put their eyeballs out further, like they're trying to look that way, but they're really not trying to. It just does that. So once again, put in the visual learners thing here. You can see these are what it looks like. Bulging eyes, tremor, diarrhea, menstrual changes, localized edema sometimes, weight loss, dyspnea on exertion, increased systolic pressure, tachycardia. These are common hyperthyroid things. Just think, remember, hyper means too much. So these are kind of all things are just amped up. That's how we get some of these symptoms. The bulging eyes, the tachycardia, the weight loss, muscle wasting. These are all hyper. So what we have to do now is medication options for one. Mostly it's actually treated with sometimes with these medications, although we can also do symptomatic treatment, like the beta blockers here are symptomatically treating the tachycardia. We can also do other symptomatic treatments like avoiding caffeine and other things that increase the heart rate. Other things with diarrhea was one of the symptoms too, so you can do things that don't further irritate that. Avoid high fiber foods, avoid really spicy foods, things that would mess up the already excited GI tract. The other option is to basically ablate the thyroid. So here, radioactive iodine, I-131. This is liquid oral intake that is selectively uptake by the thyroid. So because it's selectively taken up, you have to worry about the rest of that iodine or radioactive iodine getting out. So there's some patient guidelines as well as nursing guidelines here. Using private toilet, not sharing their utensils when they eat. All right, so in our case, Julie decided to do the iodine because she did not want to be hospitalized or take the anti-thyroid medications. Another option is a thyroidectomy. You can go in surgically and remove a portion or all of the thyroid. So for you, pre-op teaching here, it would be making sure your patient understands what they're getting ready to have done, range of motion exercises for the neck, that's pre-op and post-op, making sure you have the IVs, pain control, and make sure you have an informed consent signed by the physician and explained by the physician on the chart and ready to go. Post-op orders would look like this. Vital signs per routine and then every 4 hours. Maintaining high Fowler's position, start out on a clear liquid diet, advance as tolerated. Bunch of abbreviations here. Out of bed with assistance, QID 4 times a day, CBC and BMP. What do you think we'd be looking for here on CBC and BNP? INOs, including the JP drain, that often come out of this surgery and they still have drains in place. So include that JP drainage in your output. Nasal cannula, oxygen 2 liters overnight. SCDs while in the bed, reinforce the dressing as needed until the doctor changes the dressing in the morning. So what else is missing and what other assessment is essential? Think back to fluid and electrolytes. And what happened with calcium? What was our primary concern with low calcium? Was the airway, right? So keep monitoring the airway. All right. So we're watching for hypocalcemia. Sudden drop in their calcium can lead to tetany, dysphagia, which is difficulty swallowing, and then our big fear with the airway would be laryngospasm. So Gostick's sign and Trousseau's sign will help watch for hypocalcemia. Her post-op med orders are normal saline at 125 an hour, so that's maintenance fluid. Synthroid, so this is synthetic thyroid hormone. Why do you think she needs that? Well, we just removed either partial or all of the thyroid. Percocet, so this is an oral pain medicine, and then MS-04, which is morphine, the abbreviation for morphine. Scopolamine patch is usually used for motion sickness, but also in post-op nausea vomiting. MOM is milk of magnesia, Motrin, and Zofran. All right, you think about nursing diagnoses. So what are our priorities? Monitoring the airway, yes, but also monitoring their body temperature, activity tolerance, potential electrolyte imbalances like the calcium, airways, etc. So now we look, here's her hyperthyroid. You can see her goiter here, or smooth, palpable thing. Hair is also fine and thin. And then after we got rid of it, her hair looks better. Can't really see, but looks like the enlarged thyroid is gone. So she comes in 4 months for her follow-up appointment at 9:30 for her 8 a.m. appointment. She reports that she forgot her appointment time and was in a motor vehicle accident on the way to the clinic. You enter to find her sitting quietly with her eyes closed, sweaters wrapped tightly around her. She does not startle, but she gets up stiffly, sits on the exam table. You ask her about the accident. Her pale cheeks blush a little bit. She explains she ran into the back of another vehicle. They were both stopped at a light to turn right. She went forward after checking for traffic, but the car in front of her hadn't gone yet. Nobody was hurt. The cars weren't damaged. It was very low speed. You go on to ask her, how's she been doing otherwise? She brushes her hair out of puffy eyes and states she feels much better. She's sleeping better and things are not as crazy at home, although her husband still says she's not right. So now what do we see? In the 4 months since her surgery, she's gained 10 pounds. Not sure when her last period was. She says maybe 2 months ago, but her thyroid's no longer palpable. Hemoglobin's 9.1, calcium 8.4, so that's down. Albumin is still good. Cholesterol is way up though. Pregnancy test is still negative. Now her TSH is really high. T424 are not detectable. So what does she have now? Hypothyroid. The thyroid, then we'll talk about the difference here in primary and secondary in a minute. But in primary hypothyroid, TSH is elevated. T3, T4 is decreased. So here's what it looks like. You'll notice most of it's kind of opposite from the one hyperthyroid. Not diarrhea, but constipation. Not intolerance to heat, intolerance to cold. Slow speech. Let's get a theme here. Everything is slowed down. All right, so in primary hypothyroid, the thyroid is being told by the pituitary that it needs to spit out the T3, T4, and so the thyroid kicks out TSH, the pituitary is kicking out TSH, telling the thyroid, make hormones. but it can't. So the problem is actually in the thyroid, because apparently the pituitary is working fine because it's telling it to make more, but the thyroid can't make more. So our options here are replacing the missing T3, T4. Most common one you see now is Synthroid, is the common brand name. The generic name is levothyroxine. They will be on this most likely for life. And just like in the hyperthyroid, we can also provide symptom relief. Remember, this one was constipation, so let's promote a high fiber diet, lots of fluids, and they may need stool softener. Promote weight loss at their diet, safety, control their temperature, excuse me, monitoring that, because remember they can also have confusion and mental status changes, so making sure they can check their temperature because they may not know it's up or down. Nursing diagnoses here: imbalanced nutrition, constipation, activity intolerance, disturbed thought process, alteration in comfort. Lots of ones to choose from here. All right, and then there are a couple of emergent situations. The most important one here is thyroid storm or thyrotoxic crisis, mostly known as thyroid storm. So it's very rare. However, when it happens, it can be life-threatening. So let's take all of those symptoms from hyperthyroid and elevate them even more. So it's like everything's 10 times worse. So they get infection, trauma, surgery, things like that can elevate their hyperthyroid. So instead of just tachycardia, it's severe tachycardia, heart failure, shock, hyperthermia as high as 105, so restless. All the symptoms that were associated with hyperthyroid are just elevated. All right, and sitting right next to the thyroid is a parathyroid. All right, and this regulates blood calcium by stimulating bone reabsorption and inhibits bone formation, which is what makes us release calcium and phosphorus into the blood. So in the kidneys, it causes an increase in calcium reabsorption and phosphorus excretion. This is also what allows the kidneys to convert vitamin T to its active form. Right, hypoparathyroidism is most often caused by accidental removal. In other words, we went in to take your thyroid out and we took some parathyroid out too. Decreased calcium due to lack of PTH to maintain serum calcium levels. So treatment, they have hypoparathyroidism, so not enough parathyroid hormone. We can treat tetany, which is what they'll get from the hypoparathyroid. You can treat them by giving them calcium. This is given slow IV push, can be calcium gluconate or calcium chloride. Long-term, so that's what we would do to treat the tetany. Long-term treatment comes with calcium supplements, vitamin D, and oral phosphate binders. Most common cause of hyperparathyroid is adenoma or benign neoplasm on the parathyroid gland. So clinically, this is a loss of calcium from the bones, which means broken bones or kidney stones. This is very rare. So labs for hyper, PTH would be elevated. Serum calcium over 10, serum phosphorus less than 3. X-rays will show bone thinning. This is a collaborative care under things. So surgery, we can do that on the parathyroid. Non-surgical, we can do dietary measures, which can be watching calcium intake, phosphorus intake, and then physical therapy comes in to help with exercise, because we have a safety issue here, focusing on the safety. So the picture on top here shows patient with fragile bones, the levels of abnormal parathyroid. And this is after 7 years of treatment on the bottom. So you can see it really makes a difference. All right, now we're going to talk a little bit about pituitary gland, which is right here at this spot, right behind the nose, the base of the brain. We know the pituitary gland is the master gland. It's what tells everybody else what to do. It also, by the way, helps with our growth. Okay. There is a video here, but I can't go to it now because it is by National Geographic, I think. So I can't upload this video to YouTube because it will have copyrighted material, and I don't have a release of the copyright from National Geographic to do this. But if you go back out into Blackboard and download the PowerPoint that we would have done in class, and you put this in slideshow, you can click on it and watch it yourself. Just talks about the difference between gigantism and acromegaly and all of the medical complications that come with both of them. Because this is not just, oh, you're getting taller. It's a overgrowth of a lot of things, and we're just not meant to deal that way. So one thing we can do with here, if we have pituitary problems, is a hyphocystectomy, which is removing the pituitary. We can do this 2 ways. Craniotomy, which is going right in through the head, or the transsphenoidal. In other words, we go in kind of right into the upper lip. You go in through the floor of the nose and sphenoid sinuses. So this is what post-op, your nursing implications here are observing drainage, watching the drainage, because it really don't want to see cerebral spinal fluid come out. And we'll talk about some ways to test for that. Watching all of your other things. Urine output, if it's too low or too high. Because remember, we can have diabetes insipidus that we talked about before was a problem with the pituitary. So we want to make sure that we don't have a complication like that. So that was all about hyper in the pituitary. But if we have hypofunction, this is when we don't get enough growth hormone. This is rare, though, despite the current push for little people, which I know we've seen a lot about that. Lots of TV shows on little people. But it is rare if it's actually pituitary cause. Hypopituitary dwarfism is just one. There's multiple types of dwarfism. So this is a tumor that causes hypopituitary, which causes a decrease in the hormones it outputs. This is when you get proportionally grown little people.